Hi, happy Wednesday, and thank you for joining us for our Research in Progress webinar series. This is a bi-weekly series that we have where we have all of our Systems for Action grantees present on the progress of their research projects. So I am Carrington Lott. I'm the program manager at Systems for Action. And if you're not familiar with Systems for Action, we have funded over 30 projects over the past 5+ years that focus on rigorously testing innovative ways of aligning the medical, public health, and social sectors. And today we're going to be hearing from our team in Vermont on the impact of global budgets and community health workers on health equity, and cross-sector interconnectedness. Just a little housekeeping. We have a welcome, which I'm giving you right now, and then we'll hear from our team at Vermont, and then we'll have commentary from Carrie Wolfman at the end of that, and we'll reserve about 10 or 15 minutes at the end of the presentation for questions and answers. So if you have a question that pops up at any time during this presentation, please feel free to use the Q&A box at the bottom of your Zoom screen to enter your question, and we'll address it at the very end of the presentation. So before we hand it over to our team, I just want to give a quick minute to do introductions. So we have Dr. Adam Atherley, who is the founder and director of the Center for Health Services Research at the Lerner College of Medicine at the University of Vermont. And joining Dr. Atherley is Dr. Eline Vanden Broek-Altenburg. I did not confirm how to say your name, so I'm sorry if I mispronounced that. So she is the assistant professor with the Center for Health Services Research at the University of Vermont College of Medicine. And we have Dr. Lisa Natkin, who is a part of the team working on the Integrating Behavioral Health and Primary Care project, and she is conducting a lot of qualitative research on this project. Then we will hear from Carrie Wolfman, who will provide commentary. She currently serves as the Associate Vice President for the Community Practice at the University of Vermont Medical Group. So we're really excited to hear from everyone. And with that, I'm going to stop sharing my screen and I'm going to hand it over to Adam Atherley to share his screen.
You're muted.
Thank you. Okay, try it one more time. I just want to start, so thank you for that introduction, Carrington. I just want to start off by acknowledging that there's a very large group of people who are working on this project at the University of Vermont, and we're at the end of year one of our research, and so we're going to present a little piece of our early findings for this project. There we go. So just for those who don't remember from a year ago when we talked about it, the purpose of this project is to look at the effect of combining a global all payment reimbursement, which is statewide, with community health teams, which are also statewide and which pre-existed the global all payment reimbursement. And to understand how the effect of this alignment through the global all payment reimbursement help the community health teams to be more effective in terms of coordinating between the medical, social services, and public health sectors, and ultimately how that affected the health of the population, access to health care, health equity, and also the cost of care. In this project, we have three aims. The first is we're looking at the effect of the alignment on formal system linkages between the healthcare sector and social services and public health. The second aim, which is going to be the focus of the talk today, is looking at trying to understand how community health teams set their priorities for social, public health, and medical services and what services to offer, and how they think about what trade-offs they want to make between improving the health of their population, improving health equity, and helping control the costs of healthcare spending. And then the third aim is we're looking at the effect of the Vermont community health teams and global payment on the health risk of the population, health outcomes, health equity, and access to care. And that aim is very quantitative. As background, Vermont has a waiver from CMMI, which allows a unique model, which is the Vermont all-payer model. What the all-payer model does is it allows the three main payers of healthcare, Medicare, Medicaid, and commercial insurance, to combine their forces and route the payments through an accountable care organization, and then the accountable care organization can turn around and use global payments for providers to try to remove the volume-based incentives that's inherent in fee-for-service medicine. The key is the waiver allows Medicare participation, which is unique nationally. There's one ACO in the state of Vermont, which is called OneCare. That's not necessarily part of the waiver. There's nothing about the waiver that requires a single ACO. The point of the waiver is just allowing the coordination of payments through any ACO. And when it was first started, there was actually 2 ACOs, one of which left the market. So at this point, there's a single ACO. The hope is that what you can do, what this will allow the state to do, is transition to a standardized risk-adjusted population-based payment, which will replace fee-for-service medicine, and then ultimately move the state away from volume-based care and towards value-based care, and start to prioritize services which improve the health of the population rather than things that will maximize reimbursement. There's obviously in this kind of model a strong focus on socioeconomic factors. So there's a lot of interest in looking at the social determinants of health, because in some ways that may be the most efficient way to improve the health of the population. And ultimately, again, the goal is to create an integrated healthcare system, which has an improved patient experience for care. This is a voluntary program. The goal that is set by CMMI for the state is 70% voluntary participation from the population, improve the health of the population. And there's very specific targets that the state has to meet in terms of their targets. So for example, they have to reduce rates of chronic illness statewide. They have to reduce rates of avoidable deaths for things like suicide statewide. So there's very specific targets that they have to meet. And then finally, while you're doing all that, they also have to reduce the cost growth in the state. So the state has to average 3.5% cost growth annually over 5 years of the waiver. One of the mechanisms to try to achieve this is to use community health teams. And there was pre-existing the waiver, there was a statewide network of regional community health teams. The health teams are multidisciplinary and they're headquarters within each service's central hospital or FQHC. Historically, they've been funded by the Blueprint for Health, which was able to take funds from Medicare, Medicaid, and commercial insurance, and then use that to pay the community health teams. With the goal payer waiver coming in, now with this global payment, the all-payer ACO is able to also supplement the funding for these community health teams to try to achieve the statewide targets for cost growth and health. There are a whole lot of activities that the community health teams are responsible for. Patient-centered medical homes have been standardized in Vermont for over a decade, so they work with the patient-centered medical homes. They help connect patients to community-based services. They help support learning collaboratives within their communities, and they work with medical and community providers to try to align the statewide initiatives and take advantage of whatever resources and priorities are available in their regions. The community health teams are relied on to achieve the goals of ACO, but also before the ACO, they were in place to try to achieve the public health goals of the state. Oh, now you're muted, Alina.
Thank you. So today we'll be presenting our work in the first year for AIM2. AIM2 has an overarching research question, which is how do community health teams actually set up priorities for what social, public health, and medical services to offer? And with this aim, or with this question, we'd like to understand the trade-offs that are being made by the community health teams between health equity, and healthcare spending. And in order to address this question, we formulated 2 steps in our research. The first is the identification of the contextual factors which allow the development of attributes for a discrete choice analysis. And then step 2 is actually to quantitatively estimate how the community health teams make trade-offs in priority setting using such a discrete choice experiment. And then we'll use more advanced estimation models to quantitatively estimate these trade-offs. Today we're presenting the results from step 1, which we've been working on this first year. So the question for step 1 was, what contextual factors influence community health team leaders' decision-making process for resource allocation and service offerings. And in order to answer that question, which is primarily exploratory, we decided to use a sequential mixed methods approach. So we conducted interviews to identify the key factors and processes in decision-making and priority settings. And as I said, this is the focus of today's presentation. So the community health teams are organized and funded by health service areas, and there are 13 statewide. These purposely selected program managers representing, or we selected the program managers representing all these 13 health service areas, and we also invited them to include some of their team members if they played a significant role in decision making. And some program managers actually did do the interviews with other team members, and some of them did it individually with us. So we conducted 1 hour semi-structured interviews, which were done all via Zoom due to COVID-19, unfortunately. And 2 of the UVM team members were present in each interview. It was either Dr. Natkin or myself, and then with 1 other team member. And the interviews were conducted in January and February of this year. So the interview guide, we used an interview guide that was developed for semi-structured interviews, and we developed that in collaboration with some of our partners and stakeholders, including representatives of the Blueprint and the Vermont Department of Health. Key targeted topics include for that interview guide included what their current service offerings were, what their decision-making process looked like, whether they had a standardized process or whether it was more ad hoc type of decision-making. We also asked them about the use of data for decision-making, and that was both prior to decision-making. So was there any data available that helped you inform your decision? And also, do you collect data yourself to report back on how what your performance is? And then also another topic was the role of community partners. To what extent do they influence your decision-making when it comes to allocation of resources?
Okay, so to identify contextual factors influencing the team members' decision-making, we started our analysis process by reviewing relevant documents such as the Blueprint for Health manual. That each health service area has an annual report with helpful data and information about it. And this really helped us understand the uniqueness of each of these 13 service areas. All of the interviews were recorded and transcribed for analysis. And then we imported them into Deduce, which was our qualitative research management software. Our list of codes was developed inductively, meaning we began with the structure of the interview guide, and then we reviewed the transcripts to develop the codes, and we continuously refined the codes throughout our analysis process. First, we explored data related to each of the health service areas to identify region-specific contextual factors and really get to know what was going on, and the contextual factors in each of the different 13 service areas. And then we looked across all of the different regions to explore differences and similarities between the regions to identify cross-cutting patterns. Through progressive cycles of coding, we identified contextual factors that influence community health team leaders' decision-making for resource allocation and service offerings, and project team members and partners provided feedback on several iterations of our emerging findings. Now I will describe the 4 major themes of influential contextual factors. Each of the themes really overlap and are related to one another. The results represent the major themes, what was most prominent in the data in terms of strength and salience in relation to our research question. On each of the following slides, you'll be able to read illustrative quotations related to each of the themes to kind of help ground them in the data. Go to the next slide. So this first theme focuses on the ways in which Blueprint stable and flexible structure influences program managers' decision-making. The Blueprint really enables local teams to create their own structure and services. Each health service area has a unique organizational structure and a blend of different funding arrangements with their administrative entity and participating practices. Some community health staff workers are hired directly by the administrative entity, but they work at the participating practices. Some staff are hired by the administrative entity and work at the hospital, but receive referrals for care coordination services from the practices. Sometimes funds are passed directly to the practices so they can hire their own staff to do care coordination. And a few health service areas have arrangements with designated mental health agencies to hire staff to work in the practices. And the structure is really dynamic and based on the needs of the individual practices and the local context. The stability of the Blueprint funding, which is based on a per member, per practice calculation, consistently supports staff salaries. Blueprint's care coordination model is not fee-for-service associated with any particular insurance policy, which removes any of the financial barriers for patients accessing those care coordination services. So these team members are really able to reach typically underserved patients. These characteristics of Blueprint structure and funding influences how teams allocate their resources. Blueprint and the local community health team leaders invest in building capacity by hosting staff capacity by hosting trainings and professional development opportunities, learning collaboratives about best practices in care coordination. Sometimes program managers attempt to align needed staff credentials with existing staff through training or supporting staff getting new licenses. This ability to build capacity within their team influences their staffing decision and resource allocation. The second theme speaks to the community health team's commitment to offering high quality care coordination. Individual care coordination is the primary focus of the community health teams. They work with patients on what is most important to them. They connect patients to social and community services to address their needs and help them navigate systems of care. Again, given the Blueprint's funding structure, they're able to provide these care coordination services free to all patients. Slide. Some care teams have access to supplemental funding for staff and programming. So they're, kind of due to their commitment to offer high quality care, they're reaching out and applying for grants and leveraging community partners and hospital funding to supplement their community programs or to support additional staff. A few health service areas have been able to secure additional funding to support their desired positions, such as having a non-clinical member of their team to handle the social service logistics, or having a staff person positioned in the emergency room to help link patients that are coming in with follow-up support and social services to kind of really just help meet that critical need. When a service area receives a grant targeting a specific program or disease prevention, that really shifts their focus and that could really influence their priority setting. Many community health teams are larger than those just funded by the Blueprint, but the teams meet together regularly and work together with everyone that's doing care coordination as a cohesive team. Collaborating with extended teams and community partners helps to accomplish more with limited resources. So the third theme describes how program managers use data in program priority setting. Each health service area has a unique set of community needs that influence their priorities. Program managers mentioned a variety of different community needs, and most commonly things like patients' access to care, transportation issues, homelessness, and substance use were those that were brought up kind of across all of the areas. And teams gather evaluative data on their programs and initiatives, and they also look at utilization data and referral data to kind of determine the community's greatest needs. They also found that the community needs assessment was a very critical source of information for priority setting and decision making. Identifying what the community needs informs staffing decisions about which type of staff credentials are needed most, which then influences their resource allocation. Data-driven decision-making. The Blueprint used to create these data profiles for each of the service areas quarterly, and they were really helpful communicative tools to sit down with practices and partners and talk about their progress in meeting their health targets. And those aren't happening anymore. And so a few of the community health teams saw this need and started to create their own data reporting systems and dashboards to inform their decision-making and be able to communicate their progress. Some program managers shared that they would like to consult data more consistently when making decisions, but lack the resources and the capacity to do so. The final theme talks about shares the ways in which the community health teams leverage their community partners and local resources to influence priority setting and service offerings. Each of the service areas have a community collaborative, which is a work group of people in the community that are accountable for meeting the population health goals and targets for that region. They're important networking vehicles for cultivating partnerships and exchanging information and resources. It's helpful to have the community leaders and decision makers involved in these groups. Community partners donate their time and expertise. Blueprint funding supports staff, mainly supports staff salaries. So leveraging these community partners is how a lot of these teams are investing in community programs and making them happen. In many cases, community health teams have been able to multiply their impact through these community partnerships. However, the strength of the community partnerships varies among the service areas. Some are extremely active with a very broad scope that's beyond the Blueprint and the community health teams. They're addressing community health needs, and others are more narrowly focused on the community health team and kind of less engaged at a broader scope of the community. The strength of the community network really influences that resource allocation and priority setting. Now, the availability of local resources and services also has an influential impact. Each of the service areas has a unique makeup of staff credentials based on the local need and availability of other services. For example, if behavioral health services are extremely scarce in your region, a program manager might prioritize hiring more expensive behavioral health provider as part of their team to kind of meet that patient need. Each community has also has a unique availability of other services such as homelessness clinics, free clinics, or specialty services. And so the community health teams responds to their region's unique offerings to fill the gaps in where patient needs are. And so those are kind of the 4 major emerging themes. Then, you might be wondering how the ultimate contextual factor, COVID-19, has influenced community health teams. In some of the service areas, community health workers jumped in with testing and vaccine administration. Others were calling their patients to check in and make sure that they're getting the care they need, they're getting the medication they need, and just kind of checking in on them in general. Community health team leaders were able to leverage existing community partners to really help support the local pandemic response. They offer self-management programs, and typically those happened in person, and they switched to a virtual environment, which actually increased participation and access, and they could happen across all of the different health service areas. Telehealth services obviously increased too, and that helped address some barriers to care for some patients. A few program managers expressed concern for potential long-term trauma that patients, especially children, are experiencing due to the stress and lifestyle changes during the pandemic. This has the potential to shift priorities and services for the long term. So in conclusion, the flexibility of the Blueprint funding and the empowerment of local teams enables them to provide care coordination to all patients. This flexibility allows teams to make decisions on how to allocate their resources in response to their community's needs. Blueprint community health team leaders invest in building their team's capacity and work to increase communication and collaboration to multiply their impact. The availability of professional development opportunities and training influences how teams are able to shift staff composition to meet dynamic patient needs. Teams gather and consult data about community needs and utilization services to set priorities for programming and staffing decisions. Teams cultivate and leverage community partners to increase their care coordination capacity. Community partners help to determine communities' initiatives and programs and focus areas. Our research found these to be the most influential contextual factors influencing priority setting and resource allocation, as shared by the program managers and community health team members.
There we go. Oops, sorry, one too many. So in terms of then looping back to the original question of this issue of how does the idea of global alignment is that we should be creating this, the all payer mechanism should be creating this alignment so kind of everybody gets on the same page in terms of maintaining health. But it actually creates a little bit of a tension. Because what Blueprint did is, the way Blueprint's model was they were giving community health teams funding basically based on population, and they were giving this per capita payment. And then they're allowing the community health teams to really work with our communities and make very local decisions in terms of how they want to staff, what services they want to deliver, what priorities they want to set. And I think Lisa described this really well. They're talking with their partners. They're looking at the community needs assessments. They're taking all this local information and saying, all right, here's where our priorities are. Here's where our gaps are in terms of service offerings within our community. Here's what we're going to do. Blueprint really didn't ask the community health teams to even say what they're doing. I mean, it was just kind of wide open in terms of how the community health teams wanted to do their priorities. So they didn't have to report back on sort of what services were being provided or anything else along those lines. OneCare, on the other hand, is very different because one of the big differences is that Blueprint is providing funding for the community health teams for everybody in the community. OneCare is not for everybody in the community. OneCare is only for the attributed lives. The goal is to get 70% of the population into OneCare to be an attributed life. We're at about 50% right now. So now you have a very different set population that you're dealing with, where the community health teams with the Blueprint money can deal with everybody. There's no charge. Anybody can get services. With OneCare, really, you're only interested in the attributed lives. So that's a little bit of a tension for them. The other thing is, as I said at the beginning, that what the state has negotiated with the Center for Medicare and Medicaid Innovation is there are some very specific targets that the all-payer model has to meet. They've got to reduce certain levels of chronic illnesses. They have to control costs. They have to reduce some kinds of forms of avoidable deaths. So that's really very much a top-down approach where OneCare has these negotiated priorities that they then have to figure out how to operationalize and make happen. On the other hand, the community health teams are talking with their communities. And so you've got a top-down approach in terms of setting the health priorities from OneCare and from the all-payer model, as opposed to this sort of bottom-up model, which Blueprint allows, which is creating this collaboration. Again, the same thing, OneCare's got to control healthcare costs. And so naturally, there's going to be a focus on the medically high-risk patients and things like readmission rates. On the other hand, Blueprint can look at the more things like social determinants of health. So you can focus on different populations. One of the other things that we heard from the community health teams is, that OneCare had a lot of requirements in terms of care coordination. They might want certain kind of licensed providers be parts of the community health teams, again, as opposed to Blueprint, which allowed the teams to have a lot of flexibility in terms of how they want to staff and how they want to do licensure. And then finally, the funding is after the care coordination is documented. So OneCare built a navigator system, and OneCare wants to keep track of what services are actually being provided by the community health teams, and they want to make sure that their priorities are being met. The funding from OneCare flows in general through the practices in the hospitals, who then, the great thing about the extra funding is it allows the community health teams to potentially expand the scope of the services that they're going to offer. On the other hand, the funding may have a different set of priorities than the priorities that they're getting from things like the community needs assessment. So, and this is just all kind of illustrating this idea that there's this potential tension between this alignment mechanism, which is really top down kind of by definition, as opposed to community-based programs, which are much more grassroots and organic and sort of bottom up. Then Alina, you're
Yeah.
Can you hear Alina? Oh, you're frozen. There you go.
Yes. So, am I still frozen?
You're kind of on and off.
Oh. Okay, am I back?
Yes, we can hear you.
Back? Am I back?
Yes.
You are. I would try maybe turning off your video. Maybe that would help with your audio.
Okay, that will very much help, I think.
There we go.
All right. Do you hear me now?
Yes.
Okay. So as I said on, the goal of this first year's work, qualitative work, was to identify the key attributes that we could use in our team's set priorities. So the hypothetical question that we'll be asking them in the second year of our study is, if there are several different program options, which one would you choose? And then we would, the different choices that we give them will be based on these key attributes. So our preliminary results from this first year suggest that some of the key attributes that we'll include in these discrete choice experiments will be whether or not there's input from the team on the choice, whether or not it's a priority from either the community partners or the Blueprint or OneCare. Another key attribute will be the funding opportunities. So also funding opportunities outside of the base funding. The availability of appropriate staff. We talked at length with community health teams about maybe using the same staff. Also community resources. So what other resources can we pull from and work together with other local organizations? And also largely whether or not there is availability of data. And this is a very important attribute because a lot of the teams did say that they used data to inform decision. I think next slide.
Yeah, and so, and again, we sort of talked about the major themes that we saw in terms of the Blueprint funding, which creates this flexibility in what programs are offered and how they do it. This commitment to the care coordination and the individual care coordination that they're offering for all patients, their data, and how their community partnerships work. And then we're going to, for commentary, we're going to have Dr. Carrie Wolfman talk about her experience and her reactions.
Hi, everyone. Thank you for asking me to join you today. That was a great presentation. And I would just like to say I'm a family doctor here in Vermont. I've been in the same practice for 23 years. And about 5 years ago, I became the chief medical officer at the local hospital, which is in one of the HSAs out of the 13 that was discussed earlier. And Adam, I wish I had had this presentation 5 years ago when I was the CMO, because it would have helped me understand the differences between the funding streams and the reporting structures. It was very confusing in the beginning, and it took me quite a while to figure out who was who and what the different priorities were. But it's been a real pleasure to see the community health teams at work, and then also to help introduce the OneCare care coordination, care management team as they came on board. I was involved in the hiring of different employees for all of those areas. I'm left wondering, and I think Aline, you just commented about this on one of your last slides, about whether or not the blending of these teams will gain a lot of efficiency. As a family doctor in a local clinic, I am very happy to be able to refer patients to the behavioral therapist that came with the Blueprint team to my practice, and also to the care manager that has now been part of the team through the OneCare work and the OneCare funding. And those team players from those different sources do work together for the advantage of the patient. And it's a wonderful thing to see. It has decreased the health inequities, really increased access to things like dietitians and behavioral health care. But I'm just wondering if, despite the differences in reporting structure and funding streams, if we could gain efficiencies and improve patient outcomes, which is our ultimate goal, if we had more of a blending of those resources as we go forward. It looks like that may be some of the sort of creative thinking that's happening behind the scenes, and in my experience, it seems like that would help us gain efficiencies. But it's been a wonderful thing to be able to tell a patient of mine, you can go down the hall and see a behavioral therapist for free, and it doesn't matter that you have Medicaid. And you know, that just never happened in the past. So I've seen over and over again the advantages that these additional CHT members and OneCare members have provided for my clinic. Be happy to take any questions about that or speak further about that.
That's great. Thank you very much. And so Carrington, do we want to open up for questions?
Yeah.
Yes, I think we've reached our Q&A portions. Let me,
I was going to briefly.
I'm sorry?
Sorry. I was going to briefly react. I'm going to turn off my video again. Do you hear me now?
Yes.
Yeah, I wanted to briefly react. Thank you so much, Dr. Wolfman. So as you rightfully said, you know, it does depend on the different teams, and you know, we've learned after these 13 interviews that none of these organizations are exactly the same, and that may sound diverse, but that's also the beauty of it. I think that's the success right there. That that's what we're trying to get at, that customized, localized, integrated care approach. To react to what you were saying, as I said in the presentation, the central gathering of data is really crucial. That's one thing that we really found during these interviews, that if, you know, even though the operations are diverse, the way that we can collect data on how they're performing and to feed them data, but also to collect data from them, that could be definitely one way of integrating what they're doing. And we've definitely noted in this first year, just talking to the teams.
Thank you. So we're going to move into the Q&A portion of our presentation here today. So I invite you, if you have any questions, please enter them into the Q&A box at the bottom of your Zoom screen. I am going to move into a very easy question that came in from Chris. Is there a written report or information about this program and research that can be downloaded? If so, from where? And I will say before I hand this over to the team that we do have a project page on our Systems for Action website that we will email out after today's presentation that has all of the products associated with this project team listed on that website. But Adam and team, is there anything that maybe we haven't included on the website yet that you would like for us to share post-webinar?
We're still in the writing. We'll have this written up fairly quickly, but not from us. There's a couple of write-ups of the community health teams, but I think this is, you know, so we can certainly share that. But I think this is the first time anybody's really done a deep dive into the community health teams, because, you know, and I think that maybe this point got glossed over a little, that nobody really knows what these community health teams do. I mean, the Blueprint didn't have any real requirement. You know, Blueprint sort of said, here's the money, do good. And they've been out working very hard to do good, but there's no centralized data repository in terms of what activities are actually, you know, happening. And so that's what's kind of new here.
Thank you. And we will, as this team comes up with products, or if they have written reports or anything like that, we will include this on our website. And we always include these in our Systems for Action newsletter as well. We're always really happy to share our research team's work along the way. And this team is in progress. This is their second Research in Progress webinar, and they will be presenting again in about a year. So you can follow along with their progress as they move forward. Next question is from another one of our Systems for Action grantees, Ashley. She wants to know what were the platforms and tools used to collect and share the data, and were they similar across the community health teams?
You mean to the data that the community health teams are using, or the data that we're using to collect data?
I think and Ashley, feel free to pop in another question if I'm incorrect here, but I think what she's referring to is some of the community health teams were building their own platforms to collect data. And I think she's asking about those platforms and tools.
Right.
Those were not consistent across I mean, they were developed within the health service areas. I mean, I will say that Blueprint holds, regular meetings for all their program managers, and I think they share resources and things there, but it seemed like all the program managers were designing their own platforms and systems in conjunction with their community network. I think community members were also feeding data into these dashboards, and they were using them in their meetings with community members as well. So I think they were kind of dynamic, but the program manager were just talking about this need to respond to the lack of the profiles that were coming in. And so they decided to, create these dashboards and systems for collecting data. And, I think it's ever changing and ever evolving. And I got the sense that people were sharing amongst the program managers, but there wasn't a standardized tool by any stretch. It was, again, along that same vein of being flexible and region specific.
Thank you. Anything else to add, Adam or team?
No, the only thing I know and then speak. So other than the one consistent theme that came back is they would really like data. They don't have data really in terms of what the priorities should be in their communities. They're pulling data wherever they can, and in terms of their successes, they also don't have real data on that. So there's a real interest in getting better data in terms of what's working and what the priorities should be.
Because they also talked a lot about challenges as far as, gaining data across different EHR systems and with different, community partners and that sort of thing. So I think that they would really, love more access and more standardized data and reporting.
Thank you. Next, we'll move on to a question that came in from Molly. Can you speak to how this approach might work in a more populous state or in a state with many different ACOs?
I think that's a great question. I wondered a lot about that very same thing. I don't know, Carrie, do you have a thought on that?
I do have thoughts about it. I think it would be very challenging, as you just said. I think if I were in charge of a situation like that, I would work very hard to get some teamwork among the ACOs to set priorities. I find that unification leads to more efficiency. And I think when it comes to gathering data, the same thing. If people all have a different platform and they're all using different metrics, it's hard to make progress and really see what the outcomes are. So I think I'd work towards at least coordinating on a lot of the work. I'd make that a priority.
And in some ways, go ahead, sorry.
I was gonna say, is that something that the team is thinking about as you're having these research findings come in? Are you hoping that some of these findings might be generalizable to other states that do have different makeups of ACOs, or are you thinking that the findings will mostly be for the state of Vermont?
Well, I guess with this, I think if you can't do this successfully in Vermont, you certainly can't do this in Texas. So I think that that's the first question: is can this actually work in some ways? Vermont is an idealized environment. You've got an incredibly low uninsurance rate. You've got a fairly healthy population. You've got the primary care homes already in place. You've got all the infrastructure we think should make all of this work. So if you can't make it work here, you can't make it work anywhere. But I think so that's our first question. And then we definitely think about the generalizability, because in some ways the Blueprint model is generalizable. I mean, because Blueprint is taking funds from all the payers there, and then there's sort of giving this flat fee, that flat population-based payment to the local community health teams. And there's no reason in the world you couldn't, instead of doing it to 13, do it to 1,300. You could scale that up fairly easily.
And Adam, I think I interrupted you to ask that question. Was there something else that you wanted to add before that?
Oh, no, that's all.
Okay, great. So we'll move on to another question that came in. Can you just give an example of what a community health team consists of?
Lisa or Lena? Yeah.
Sure. So I just pulled up one of my background documents. So it's a variety of people that are care coordinators with masters, or mental health and substance use clinicians, or licensed social workers, registered nurses, you know, behavioral health providers. So it's kind of that mix, and it registered dietitian, if I didn't say that. And so it's kind of a mix amongst all the different teams, depending on their needs and how they want to make that work.
Thank you, Lisa. So a question came in from Jessica. You mentioned activities of some community health teams are limited by the community resources available, or those that are not available in their health service area. What are community health teams doing to increase the availability of social support services in their communities or in the state of Vermont generally?
I'd be happy to give an example in my HSA here in Middlebury, Vermont. The community health team actually considers itself to be a large group of people who gather together at least once a month to be on the same team, supplying and supporting health in our community. And members from entities such as the Department of Health, Home Health and Hospice, our designated agency, which is our mental health agency here in the county, the Parent-Child Center, Public Transportation, our Turning Point Addiction Recovery Center, and Planned Parenthood are some examples of agencies that come together and participate. So I think those entities continually assess their resources and talk together in that team about how to support each other and the resources that are needed.
Thank you, Dr. Wolfman. Chris Hollis would like to know if you have community health workers on the teams.
I'm looking at the others. I believe so, but yeah.
I think Julie Barker is considered community health worker as well, or she's basically in charge of all the teams. So technically, I think she's in the field, correct?
Yeah.
That's kind of a question mark though. But yeah, when I mentioned partners and stakeholders, we are closely collaborating with the person in charge in Vermont of all the community health teams. So she's connecting us, and she works very closely with all the teams.
Thank you for clarifying that. This question here from Dana. You mentioned the success of self-management programs moving to the online structure. Did any community health teams mention concerns around funding and structure of these programs moving forward?
Lisa?
Yeah, they didn't. Yeah, they didn't really, they just mentioned it more in terms of the fact that their patients could now access some of the self-management programs outside of their individual health service area because everything was virtually, but they didn't mention the OneCare piece of it. So I'm not sure. That wasn't really kind of brought up in the interviews.
Okay, we had a question come in to the chat. Does Vermont have an all claims database?
Yes.
Okay, it's an easy question, easy answer.
Yeah, and we're using that for our quantitative analysis. So because again, part of the key is, we want to really understand how these community, now we have an idea. We're trying to get an idea of what the community health teams are doing and where their priorities are. And then once we know that, we can then try to use the secondary data sets to try to analyze whether or not they're actually making differences in terms of utilization, costs, and outcomes. And that's what we're using the APCD for.
Thank you. We have a question from Dave. Were the positions on the community health teams designated for patients, community members along the lines of nothing about us without us?
a couple of program managers kind of mentioned that mantra, a couple of different versions of it, not necessarily positions on the community health teams, but definitely working in collaboration with patients and community members on programs, especially again in that the community collaborative, inviting people, specific patients to get involved when they're having these work groups and planning groups and sessions when they're trying to target different initiatives, you know, making sure that that patient voice is there.
Great, thank you. We don't have any other questions in the Q&A box, but I did have one question myself about theme 4 that you had, leveraging community partnerships and local resources. And I guess my question is, how does that strength of the community networks vary? And are you seeing commonalities across the different regions of who in the community is collaborating more or less?
What do you mean by who? Like the types of organizations,
like,
or?
Exactly.
Right,
yes.
So some of the community collaboratives existed kind of prior to, like some of the health service areas had existing, you know, entities and groups that were doing collaborative activities around population health and public health prior to the community health team. So I think that those service areas kind of have a stronger history and, you know, just longevity as far as that collaborative piece. But I didn't notice any differences about like types of organizations that did or didn't participate. And AIM, one of our studies, is going to be diving into that a little bit more, like the network mapping of who is collaborating with who, kind of. But I would just say that, you know, program managers, I think, you know, are really using those opportunities, and like Dr. Wolfman was describing, of meeting with, you know, different community entities to make sure that everyone is aware of all the different resources that are available in the community, so that they're not, you know, duplicating services, and that they're really utilizing everything that's out there. And so using these meetings as a way of making sure that all care coordinators, regardless of funding, are aware of all the different unique resources and opportunities and organizations that are working in, you know, working together on public health. I would say, as you know, you're asking about the strength of the community collaborations. I think some of them had a lot more of the higher ups and the leaders involved. And I think that that kind of program managers mentioned that making a difference. But the folks that didn't have the leaders involved didn't mention it. So it was more the folks that do have it mentioning how helpful that is to say, hey, we've got the CEO here. So when he's on board, he sets the tone, or, you know, we've got this leader here who can really help kind of shift things around and help support things. And I just really love the idea that, you know, the community partners are donating their time and expertise so that these community health teams are really able to offer more things. And there was a great example of, I think it was in one of the quotes of, you know, working on this resiliency campaign and how all the community partners came together and were working with schools and parents and, you know, just helping to amplify everything that they're doing. It was kind of a roundabout answer to your question, but there wasn't a direct answer, I don't think. But I think AIM, yeah, AIM 1 might help, so stay tuned.
Well, great. Thank you for answering that. I was about to end this, but I just saw another question come in. So if you don't mind, I'm going to ask another question if you're up for it. Chris Hollis wants to know about the community collaboratives. Do you find that business has membership in these collaboratives? If so, any thoughts on how to motivate them to do so?
Lena or Lisa?
Yeah, I mean, I do remember, and Lisa, feel free to add, I do remember talking to some teams briefly about this, and it was more like local, not so much grants, but local support, especially during COVID. There was, you know, there was support from supermarkets and examples like that. And I did get the feeling that all the teams that mentioned business partners like that were definitely using them to the fullest extent. But if you're suggesting that that might be an avenue to further explore, I very much agree with you. Want to add anything?
No, I mean, just that I think that's a cool thing to start thinking about. How can we get more? I feel like one health service area talked about a group of businesses that work together outside of the community health team on public health initiatives, but I don't remember all the specifics around it because it was just one of the service areas, but that's a really cool idea to explore further. It certainly is in everyone's best interest to increase health and wellness.
We have another question that came in too, so I'm gonna ask this, and I think that's probably all we're gonna have time for today. But Jessica has a question about the top-down approach in Vermont. Is this preferable to a bottom-up approach? And she references Vermont's community health teams that were created and funded by the state to serve all residents, but some interdisciplinary health teams are established and funded by private entities in response to the shift to value-based payment models.
Adam, do you want to go first?
Yeah, because in some ways, I feel like Vermont has both of these models, and I'm not.
That's exactly what I was going to say. Yeah.
Yeah, I mean, in some ways, that's that tension that we feel like is kind of there. Of Carrie, when we were talking earlier, you were sort of saying how everybody's kind of trying to do the same thing, but they have sort of different. They're answering to their different pots of money that are funding them, and they may have the different priorities, but they're all kind of working in the same direction. I don't know, Alina and Carrie, do you want to add?
Yeah, that was very much what I was going to say, because initially I thought, officially it's a top-down approach, but in practice, talking to these 13 program managers, that's not at all what I'm getting. In fact, I'm getting quite the opposite in practice, and that's why I feel like, speaking of success, I mean, I do think that these teams are already a huge success when it comes to putting care coordination to practice. It's just a matter at this point of sort of fine-tuning coordination at the state level, but they are very much locally working from bottom up. And the previous question actually very much is related to this. They are actively seeking out partnerships locally. They are actively partnering for smaller pots of money projects. And they have an enormous freedom to decide what to focus their resources on. So in that respect, I wouldn't say at all it's top down. So it's probably a bit of both.
Carrie, do you have a last thought on that?
Sure. I prefer not to use those two terms, top down and bottom up, but prefer to look, and I think the group, all of these teams are looking at where the need lies. Where do the patients have the greatest need? And we're using risk stratification models and social determinants of health to find those groups so that we can direct resources there. So we're studying metrics that apply chronic disease metrics, ER utilization metrics, and then putting our resources where we can make the biggest impact and where there's the greatest need. And I think both the ACO and the Blueprint here in Vermont and all the associated healthcare entities have that in mind as their primary goal.
Yeah, there was one last thing I wanted to add that we may not have emphasized during the presentation is we came across enormous patient-centeredness in these approaches, meaning that some patients may have been referred for, let's say, dietary concerns. And then a lot of these teams say, we actually started by asking the patients what they thought they needed help for, because their reasoning was, if they don't want to get help, then we can top down whatever we want, but it's not going to do anything. So we start from the actual ask, and then from there on, we sort of broaden the scope to what they were initially referred to, which I think is very much of a bottom-up approach, or I would say more of a patient-centered approach.
Wonderful. Thank you for providing a little more insight into that. So that brings us to almost the top of the hour. I just want to thank the team for joining us today and giving an update on their research project, and for Dr. Wolfman for joining and providing some very insightful commentary. And thank you all for joining and asking questions and probing this project on what's happening with them. And we will be sending out a follow-up email with a link to this recording and to the slides after today's webinar. And we also have a survey that will pop up after you close out of the webinar that will ask you to just rate this webinar, let us know what you think. And we also are offering certificates of participation. So if you'd like one of those, you can say so in the survey and we'll make sure that you get one. But thank you again for joining, and thanks to the team. We hope you have a good day.
Thank you. Thank you, Karen.
Bye.
Thank you.